Hello, this is Dr. Ayub. Actually, after a long time, I came back to the lecture mode because I was little not very good feeling situation, but I was not attacked by COVID, but physically I was not very potent to keep all these lectures. But today I feel like I should start, and that's why I came back before you, and let's talk about the female reproductive systems pathology. So if you follow my previous lectures, you will see I discuss a lot of things: anatomy, physiology, and details of anatomy, details of physiology, especially the two cycles, that's ovarian cycles and menstrual cycles. And then I discuss about the clinical signs, symptoms of some diseases, and the techniques that applied for the pelvic examination, all methods: trans-abdominal, trans-vaginal, trans-labial, even trans-rectal, and all the preparations, precautions, patient's positions, transducer selections, orientation of the trans-vaginal examinations, and indications of ultrasonography, a lot of things, even though some lab values I discuss and other modalities used for the female pelvis evaluation, I discuss all those things. So now this would be the last part, that is the pathology of the female reproductive system. And in this lecture you will see I will discuss about the pathology of the uterus, pathology of the ovaries, and pathology of the pelvis. That I'm going to start first. Okay, let's talk about the pathology. So for any organ or any system, in order to understand the pathology, so you have to understand that some pathology, if you classify, if you group all pathologies, you will see some pathologies are from birth. We call it congenital anomalies, and some pathologies are inflammatory due to infection, and that infection can be bacterial, viral, fungal, and then parasites, and a couple of other some organisms, spirochetes for the syphilis, you know that, and some pathologies are cystic, some pathologies are solid. Cyst can be in two ways. One is congenitally, there might be cyst, multiple cysts. It's due to the developmental weakness of the wall of the ductal system, so that can cause congenital multiple dilatations of the tubes. And another cyst usually comes from the retention cyst due to obstruction. We call it retention cyst. Sometimes some structure may look like cystic. It is due to the necrosis of the tissue. Necrosis of the tissue due to any causes, maybe compromise with the supply, oxygen and nutrition, and some cells some tumor can compromise. It could be benign, it could be malignant. Okay, so these are the cystic where sometimes you will see multiple cysts, sometimes you will see isolated solitary cyst, and most of the cysts are simple cysts are benign in nature. Then you can say that a solid mass is another pathology, and the solid mass can be benign, can be malignant. And the malignant and benign version of the solid tumor may have their cystic component part. Example, adenoma is a solid, right? Then cyst adenoma is cystic version of adenoma. Same thing. Adenocarcinoma is a malignant, and the cystic version of that malignant is cyst adenocarcinoma. And this type of classifications are common for the ovary, and also you saw it in the pancreas. Pancreas carcinoma can be cystic also. Okay, so after the cystic, then after the solid version, so then we can see some traumatic cause. Trauma can cause pathology too. Some disease can be autoimmune. Okay, so some disease may have antigen antibody reaction, and body develop antibody against its own body. So autoimmune disease. Some diseases can be unrecognized. We call it idiopathic. Okay, so in that way some organ can have multiple pathologies. But for the female reproductive system, there are very common diseases that most of the time we will see the patient comes with that symptoms and sign, and the doctor examine, taken the history, doctor do the physical examination, and then they need a blood report and ultrasonography. In addition to ultrasonography, patient may need other modalities, simply plain X-ray, then CT examination, MRI, then arteriography, nuclear medicines test. Okay, that's so many types of modalities can be used for diagnosis of the disease. Okay, let's talk first about the inflammatory processes of the pelvic organs. So inflammatory processes, that first I'm going to discuss about the pelvic inflammatory disease. We call it PID. Let me give you the idea about the PID. PID is a pelvic inflammatory disease, and the most common cause of the PID is STD, sexually transmitted disease. And what are the sexual transmitted disease? Syphilis, gonorrhea, chlamydia. Okay, so this is the most common sexually transmitted disease. And PID is one of the major cause of ectopic pregnancy, and also one of the major cause of infertility for the woman. Okay, I'm saying again that inflammatory disease in the pelvis is the number one is PID, pelvic inflammatory disease, and the pelvic inflammatory disease complication, the number one complication is ectopic pregnancy, and the most common causes of PID are STD. And if a patient has pelvic inflammatory disease and later on they get pregnancy positive, it could be most of the time ectopic pregnancy. Okay, so now lot of girls in their young age, even the middle age, they suffer from the PID. And the etiology are the STD, sexually transmitted disease, and other cause of infection that can spread from the other organs, other systems, and other body component parts. And what would be the clinical informations? The clinical informations will be patient will come to the doctor with symptoms of what? A non-specific pain in the lower abdomen. Non-specific pain. With infertility. With heavy period or bleeding during menstruation. And in PID, the organs that get involved in the disease is all organs in the lower female reproductive system, including any anatomy in the pelvic cavity. So PID can involve the fallopian tube, the broad ligament, the ovary, uterus, and the pelvic adnexal area, soft tissues, and other muscles. Everything together can cause PID. Okay, so patient in their teenage, in their conjugal life, in their after birth, in the middle age, they don't feel good. All the time they will complain, oh, I'm suffering from this, okay, I'm not feeling good. They don't go for amusement, they don't go for anywhere that can feel good. No, they don't, because they are depressed. They are anxietyful. Why? They don't feel good. Okay, so it is very important that we need to understand that patient may come with all those scenarios. Then we need to figure it out. Where is the problem? Is it uterus is bothering you? Or fallopian tube is bothering you? Or ovary is bothering you? Or the any other tissue in the pelvic space is bothering you? Or sometimes pelvic venous congestion. Pelvic venous congestion, especially for the female, it is also more common. In one article I read that 1/3 of the girls' pelvic pain is due to pelvic venous congestion. And that is the dilatations and tortuosity called varicosities, formation of the veins in the pelvic area due to congenital lack of valves, and prolonged standing, working as a standing, prolonged time, keep bearing the heavy load, coughing, sneezing, they feel lot of pain. Especially it happens during the period. Okay, and after the period they feel good, and also they feel good when they come home and they lay down flat on the bed and they feel much better. Okay, so now if the pelvic inflammatory disease is in the fallopian tube, and if in the ovary, I will tell you there is some chance of infertility. Why? Because the fallopian tube, as we discussed before, it is a funnel tube-like structures, like a trumpet shaped, collapsible tubes. Due to PID, the fallopian tube can be inflamed, causing adhesion. Adhesion can cause obstruction. Inflammation can cause hydrosulfings, pyosulfings, hematosulfings, and as a result the fallopian tubes are kinking, tortuous, and adhesion. If it happens like that, understand, when the ovary gives the ovulation, the egg is supposed to be caught by the fimbriae of the infundibular part of the fallopian tube, and because of the PID, the fallopian tube is tight, adhesioned, and face away from the ovary. Ovary is here and the fallopian tube is like this. How they going to grab the egg from the egg, ovum from the egg? It's not possible. And that is one. Another one is, due to kinking, tortuous, and obstruction, even though there is a fertilization in the ampullary part of the fallopian tube, the fertilized egg cannot proceed towards the endometrium of the uterus because fallopian tube is closed. Just understand what a disaster. The couple is trying to get the baby, but it's not happening. But you know what? There's a nice treatment for it. What is that? The nice treatment is laparoscopic exploration of the pelvic cavity. That usually goes laparoscopy through the abdomen. And they clean the all adhesion, tightness, obstruction, any suspicious bad things. They can clean all those things, making the fallopian tube freely moving. And then the girl, after 2-3 cycles, when the cycle is regular, and they will try, and they are being mom and dad. Okay, so this is important to understand, that how the ultrasonography can help, or other modalities used to understand whether the pelvic organs are doing good. Some other tests or modalities, you know, that hysteroscope, caldoscope, then hysterosalpingography, then saline sono hysterogram. So that we discussed before, right? So all those tests should be practiced according to the complications. Okay? So then, if there is infections to the uterine perimetrium, we call it perimetritis, that can be treated as a pelvic inflammatory disease. Then endometrium, myometrium, and perimetrium, all 3 layers can be infected too, and that belongs to the pelvic inflammatory disease. If there are infections to the ovary, we will call it ophoritis. And ophoritis is the inflammations of the ovary, and as we know that ovary is attached with the posterior wall of the broad ligament. So inflammation is spread to everywhere. And ovary, if it is tight and ovary is not getting chance to release the egg, so egg can be destroyed. It can be misutilized. Another one, that if the infections to the ovary happens and the ovarial infection will spread to the fallopian tube with the broad ligament. At that time, what is going to happen? The ovary will be attached firmly with the broad ligament, pelvic fossa, and also with the fallopian tube, and it is an infection. So now there is infection to the fallopian tube, then ovary, broad ligament and other soft tissue, and it causes a complex mass with collection of exudative fluid, infectious fluid, even though pus. We call it tubo-ovarian abscess. It's a very dangerous situation. Very big infection. Patient is very sick with high rise of temperature, and I will tell you, patient has immunocompromised, because that big abscess developing in the pelvic cavity means patient's resistance is very poor. Okay, and definitely patient needs to be hospitalized, and patient needs to be evaluated by ultrasound, by CT, MRI, whatever the availabilities, and patient needs to be treated seriously. Infection can migrate to the uterus, perimetrium, myometrium and endometrium. Okay, so we have to be very careful about these infections. Okay, and simply patient may have infections to the pelvic floor. So these are the important concept that we need to understand about the PID, and then we will discuss about the sonographic appearance of the PID. So let me read it, and I will explain more with the diagrams about this PID. I'm just giving you the preliminary introductory lecture. So now I will go over my notes, and then you will understand the pelvic inflammatory disease. This is a general term given to an acute inflammation of the reproductive organs and the support structures. Okay, acute inflammation of the reproductive organ, female reproductive organ and its support structures. Etiology: 99% cases of PID are caused by an infection from multiple bacteria. The most common are bacteria from sexually transmitted disease, STD, such as gonorrhea, chlamydia, syphilis, etc. The peak incidence in women in their late teens and early 20s. PID is also found in instances of poor personal hygiene and IUD. IUD use can cause PID. Poor personal hygiene can cause PID. Make sure we understand that. Clinical information: common sign and symptoms: pelvic pain with purulent vaginal discharge. Purulent means pus-like. Vaginal discharge with a bad smell. Tenderness on vaginal examination. Tenderness on vaginal examination. Usually the examiner, that is physician, will insert the two fingers into the vagina and patient will feel serious pain. And the increased WBC, fever and nausea. Okay, so all those complaints with the patient come to the doctor. What are those? The pelvic pain, the purulent vaginal discharge, too much pain, tenderness on examination, and WBC count will be increased. There will be fever and nausea. Nausea is nauseatic, throwing up tendency. Patient cannot eat or drink that much. The locations of the PID. PID may receive a specific mass based on the location of inflammation. Most common location is the fallopian tube. We call it salpingitis. salpingitis. Uterine sarcoma, uterine serosa means outer layer, and the broad ligaments, we call it parametritis. Parametritis. Salpingitis is the infection of the fallopian tube. Parametritis means uterine serosa, means perimetrium and the visceral layer of the peritoneum. Broad ligament are known as parametritis. And another is a myometritis and endometritis. That is the infection of the myometrium and endometrium. And inflammation of the ovary, we call it ophuritis. Okay, so there are a lot of itis we need to remember. Salpingitis, parametritis, myometritis, endometritis, and ophuritis. Okay, so those are the important things we need to understand. So now, if I go little details here, the etiology is the most common, is the STD. Etiology most common is STD, and it is 99%, and it's from multiple bacteria, and the peak incidence is teens and early 20s. Okay, and also due to poor personal hygiene and IUD use. Okay, and the clinical informations, patient will complain pelvic pain, vaginal discharge, tenderness too much, increased WBC. Patient will complain fever, and nausea. Okay, so if I take this